Welcome everyone. Today we are going to talk about arthrodesis of hip joint. Arthrodesis of hip is the surgical fusion of the hip joint. It is infrequently done nowadays due to excellent results of total hip arthroplasty. We have to remember the position of hip in hip arthrodesis. It can be remembered as flexion, adduction and external rotation or FADR. The optimal flexion is 20 to 30 degree, optimal adduction is 0 to 5 degree, and the optimal external rotation is 0 to 15 degrees. Coming to the indications of arthrodesis of hip joint. In present day, there are very limited indications. The classical indication used to be a young high demand patient who is usually a laborer with severe arthritis of hip, which is usually post-traumatic. Now, for a hip arthrodesis, there should be a normal function of the lumbar spine, contralateral hip and ipsilateral knee, as these joints undergo severe stresses after a hip arthrodesis. Painful spastic subluxed or dislocated hips in ambulatory patients with cerebral palsy or other neurological disorders also form an indication of hip arthrodesis. It is also a salvage option for a failed total hip arthroplasty. Coming to the contraindications of hip arthrodesis. There are absolute contraindications and relative contraindications. The only absolute contraindication is active sepsis of the joint. So if there is infection of the joint, we must treat it and the joint must remain free of infection for a few months before arthrodesis is attempted. The relative contraindications are severe degenerative changes in the lumbosacral spine, contralateral hip, and the ipsilateral knee. A contralateral hip arthritis or an active pathology of the contralateral hip or a contralateral hip fusion also form a relative contraindication. Poor bone stock due to osteoporosis or iatrogenic cause like proximal femoral resection of tumor is also a contraindication of hip arthrodesis. A limb length discrepancy of greater than 2.5 cm is also a relative contraindication. Coming to the functional results of hip arthrodesis. After a hip arthrodesis, there is generally excellent to good pain relief. However, low back pain, limited ambulation, and sexual dysfunction have been reported. Hip arthrodesis causes increased stress on the lumbar spine, the contralateral hip, and the ipsilateral knee, leading to degeneration, which becomes symptomatic around 15 to 25 years after arthrodesis. Back pain is the most common symptom, which presents in around 75% of the cases, and ipsilateral knee pain in around 54% of the cases. After a hip arthrodesis, there is increased energy expenditure for ambulation and reduced efficiency of gait. Proximal femoral fractures are found sometimes due to increased stress near the vicinity of the fusion site, and peri-implant fracture of shaft of femur have also been reported. Coming to the techniques of hip arthrodesis. This can be classified as extraarticular arthrodesis and intraarticular arthrodesis. In extraarticular arthrodesis, the hip is fused outside the joint capsule. It used to be done earlier for the fear of clearing up the joint infection. However, with the availability of high-end antibiotics, nowadays this is more of a historical procedure and intraarticular arthrodesis is mostly preferred nowadays whenever it is done. Coming to intraarticular arthrodesis, it is fusion of the joint inside the joint capsule. That is, the articular surfaces are fused. Intraarticular arthrodesis involves removal of articular cartilage of the femoral head and the acetabulum followed by fusion. Coming to extraarticular arthrodesis. Now we have already discussed it is mostly of historical importance. However, two procedures which have been very popular are iliofemoral arthrodesis and ischiofemoral arthrodesis. The iliofemoral arthrodesis was designed by Albee, who is known as the father of hip arthrodesis. The ischiofemoral arthrodesis is also known as the Britain's procedure. Now, this is sometimes asked by examiners. So, what is this? This involves a subtrochanteric osteotomy with medialization of the shaft to act as a pelvic support. This is followed by an incision of the ischium or making a recess in the ischium, and a tibial corticocancellous graft is pushed into this ischial defect through the osteotomy site, and no fixation is done. Coming to intraarticular arthrodesis. All cases of intraarticular arthrodesis require an arthrotomy and dislocation of the femoral head. This is followed by removal of articular cartilage and preparation of the fusion site. Following this, we fix the hip through one of the methods of fixation. The methods of fixation are cancellous screw fixation, anterior single plate fixation, double plate fixation, sliding hip screw fixation, and the Cobra plate fixation. Let us look into the arthrodesis with Cobra plate fixation. What are the steps? So, the first step is putting the patient in supine position with a sandbag under the ipsilateral buttock. A longitudinal mid-lateral incision is taken along the femoral diaphysis, or a curved incision like in a Cocker-Langenbach incision is taken. The fascia lata is opened and the anterior and posterior margin of gluteus medius is exposed. This is followed by a greater trochanteric osteotomy and elevation of the fragment superiorly along with the abductors. This is done to prevent the abductor function. Now, following this, superior and anterior hip capsulotomy is done with dislocation of the hip joint anteriorly. Following this, removal of the articular cartilage of the femoral head and acetabular is achieved, following which a transverse innominate osteotomy is done between the iliopectineal eminence and the sciatic notch, and the distal hemipelvis or the distal fragment is medially displaced. This is followed by fixation with a Cobra plate after contouring and placing the hip in the desired position of arthrodesis. Additional compression may be achieved by using a tensioning device distal to the distal part of the construct. This is followed by closure of the hip capsule and reattachment of the greater trochanter. Coming to total hip arthroplasty after hip arthrodesis. This is indicated for pain and generalized loss of function due to immobility or malposition after a hip arthrodesis. It is a technically demanding procedure, and the best results are obtained in young patients with shorter fusion times. This procedure has higher rate of complication including infection, revision, and resection arthroplasty. So, infection must be very carefully ruled out with inflammatory markers like ESR, CRP, and if needed, hip aspiration and biopsy. A preoperative CT scan and CT based navigation may help in planning the femoral neck cuts and placement of the implants. A special case is when a patient with hip arthrodesis requires a total knee arthroplasty of the same limb. It has been observed that if the hip is first converted to a total hip arthroplasty before the total knee arthroplasty, the results of total knee arthroplasty are better. So in these cases, doing a revision of the arthrodesis to a total hip arthroplasty before doing the total knee arthroplasty is often recommended by some authors. So friends, this was a discussion on the topic of hip arthrodesis, which is a very important topic for postgraduate students. If you like these videos, please hit the like button and subscribe to the channel for further videos. Also, comment in the comment section regarding the topics you would like to be covered in the future videos. Thank you.